Hello, this is your weekly pelvic health research review for May 8th, 2026, presented by Erwan Lerumeur, physiotherapist in Paris. This week, the Watch retrieved 170 articles. Here is our selection. The full reference list is available in the description. Today's issue starts with the key papers, a meta-analysis on endometriosis staging and pain, a randomized trial on botulinum toxin injections for provoked vestibulodynia, a review on urinary symptoms in Parkinson's disease, and a colorectal surgery trial combining hemorrhoidectomy with polidocanol foamsclerotherapy. Then we move into the thematic review, pelvic pain, continence, anorectal disorders, sexual health, postpartum care, diagnostic tools, and emerging technologies. We will finish with a few brief items lighter but worth keeping on the radar. This review is for information only. It does not replace critical reading of the papers or medical advice when needed. Top stories / the must-reads. First must-read, the meta-analysis published in the Journal of Minimally Invasive Gynecology by Alves et al. It explores the relationship between endometriosis staging and symptom type or intensity. The clinical question is familiar. Does more advanced anatomical disease necessarily mean more pain? The authors reviewed studies linking RASRM or enzyme classifications with pain symptoms such as dysmenorrhea, dyspareunia, dyschezia, dysuria, and chronic pelvic pain. The main finding is clear. Pain intensity does not simply follow RASRM stage. Severe pain may occur in early stage disease, and advanced anatomical disease does not automatically mean higher pain intensity. Dysmenorrhea appears as the most intense symptom overall, while dysuria is lower on average. Chronic pelvic pain, however, seems more frequent in advanced disease. For pelvic health physiotherapy, this matters. Imaging and surgical staging are useful, but they do not fully explain pain. The practical message is precise. We need to distinguish anatomical severity, nociceptive drivers, sensitization, functional impact, avoidance strategies, pelvic mobility, urinary symptoms, and bowel symptoms. Stage can guide the discussion, but it cannot rank the patient's pain by itself. Second must read, the randomized double-blind placebo-controlled trial published in the American Journal of Obstetrics and Gynecology by Pelletier et al. It evaluates electromyography-guided botulinum toxin injections in provoked vestibulodynia. 60 patients were randomized to receive either onabotulinum toxin A or placebo injections into the superficial perineal muscles under electromyographic guidance. Outcomes included pain, quality of life, and sexual function at 3 and 6 months. At 3 months, pain decreased more in the treatment group. Quality of life also improved at 3 and 6 months. Some sexual function items, including satisfaction and desire, were better in the botulinum toxin group. This paper directly tests a muscular hypothesis in vestibulodynia. It does not mean that every case of vestibulodynia is muscular. It suggests that a subgroup of patients with identifiable muscle dysfunction or hypertonicity may respond to a targeted intervention. For PTs, the message is twofold. Careful muscle assessment remains relevant, and when physiotherapy alone is insufficient, discussion with medical colleagues about targeted options may be justified. Third must read, the systematic review and meta-analysis published in European Urology OpenScience by Ohtsuka et al. It focuses on non-pharmacological and non-surgical interventions for lower urinary tract symptoms in Parkinson's disease. The authors included 16 studies, including 13 randomized trials. The most consistent signal was a modest reduction in urinary incontinence episodes over 24 hours. Findings were less certain for urgency, symptom scores, bother scores, voiding frequency, and urinary quality of life. The result is not dramatic, but it is clinically useful. In Parkinson's disease, urinary symptoms are frequent and complex and rarely purely peripheral. Realistic goals may include reducing some leakage episodes, improving behavioral strategies, adapting timing, improving safety, reducing bother, and coordinating exercises with motor and cognitive fluctuations. Fourth must read, the randomized open-label trial published in Diseases of the Colon and Rectum by Yin et al. It studies Milligan-Morgan hemorrhoidectomy combined with 3% polidocanol foamsclerotherapy for grade 4 hemorrhoidal disease. This is a small single-center study with 36 patients, but the outcomes are relevant for functional recovery, return to daily activities, pain, bleeding, analgesic use, symptom scores, vesi-incontinence scores, and satisfaction. The combined treatment group returned to activities earlier by roughly 6 days. Postoperative bleeding and analgesic use were lower. No major adverse events were reported. This paper does not redefine surgical indications by itself, but for PTS following patients after anorectal surgery, it is a reminder that postoperative recovery is not simply the operation worked or it did not. Time to resume activity, pain, bowel confidence, continence, and fear of defecation are functional outcomes worth tracking. Thematic review, pelvic pain, endometriosis, and conservative care. This week includes several papers on endometriosis, but the quality is uneven. Van Haaps et al. Published a Dutch modified E-Delphi procedure in the European Journal of Obstetrics, Gynecology, and Reproductive Biology. The aim was to standardize medical pain management in endometriosis. This is not a randomized trial, it is expert consensus. Still, it has practical value because it proposes a structured stepwise approach. The third step includes tricyclic antidepressants when neuropathic pain is suspected. The authors also discuss short-term opioid use, muscarinic receptor antagonists for bladder endometriosis, COX-2 inhibitors, and gastrointestinal measures such as magnesium hydroxide. For physiotherapists, the point is not prescribing, it is understanding the medical reasoning around these patients. When pain becomes neuropathic, when bowel symptoms influence pain, or when bladder symptoms are involved, physiotherapy needs a more precise framework than relax the pelvic floor. Lee et al. Published a prospective pre-post study on tenors used during endometriosis pain flares. The study is uncontrolled, so evidence quality is low. The main pain score decreased, but not clearly enough to prove a robust effect. Quality of life improved on the EHP30, and ibuprofen use decreased. The study does not prove that TENS treats endometriosis. It suggests that a simple tool used during pain flares may help some patients cope better and reduce occasional analgesic use. Clinically, this supports structured testing, clear parameters, indications, contraindications, and response criteria. Pelletier et al. In vivo compared symptom burden in isolated adenomyosis with peritoneal or deep infiltrating endometriosis. It is a retrospective study, so caution is needed. Still, the message is useful. Isolated adenomyosis may produce a symptom burden comparable to some forms of endometriosis. Dysmenorrhea, chronic pelvic pain, dyspareunia, and bowel symptoms are common. For practice, this is a diagnostic reminder. A patient with cyclic pelvic pain, dyspareunia, and functional impact does not fit neatly into either visible deep endometriosis or unexplained pain. Adenomyosis should remain part of the clinical landscape. The PT's role is not to diagnose it, but to recognize patterns and refer appropriately. De Blasio et al. In Acta Psychologica explored resting EEG changes after 8 weeks of acupuncture in women with endometriosis and chronic pelvic pain. The study is small and lacks an adequate control group. It does not allow conclusions about the specific effect of acupuncture. However, it suggests that some EEG markers, especially alpha band activity, may be associated with pain severity. This is a weak clinical signal, not a practice-changing paper, but bladder, continence, and rehabilitation. Urinary continence was a major theme this week. Lee et al. In the International Journal of Gynecology and Obstetrics published a meta-analysis on magnetic stimulation for female stress urinary incontinence. 17 studies and 1,389 patients were included. Results suggest improvements in incontinence status, quality of life, 1-hour pad test, maximum urethral closure pressure, and fast twitch pelvic floor EMG signals. However, pelvic floor muscle strength in the 24-hour pad test did not clearly improve. The interesting point is that a technique may improve some continence-related outcomes without clearly increasing voluntary muscle strength. If the goal is fewer leaks or better quality of life, strength testing alone is insufficient. If the goal is voluntary contractile performance, magnetic stimulation may not be the central answer. Chen and Zhang in the International Urogynecology Journal published a meta-analysis on PFMT for postpartum urinary incontinence. 19 randomized trials were included. PFMT improved pelvic floor muscle strength and endurance. However, direct effects on urinary incontinence incidence and quality of life were less certain. Supervised programs lasting more than 8 weeks seem more effective for improving strength. The practical message is honest but not negative. PFMT remains defensible postpartum, but expected outcomes should be clear. Improving muscle function does not automatically resolve every symptom. Timing after delivery, breastfeeding, fatigue, pain, type of leakage, training load, and adherence all matter. Sanchez-Martin et al. In the American Journal of Obstetrics and Gynecology published an observational meta-analysis on physical activity, sedentary behavior, and urinary incontinence in adult women. More than 295,000 women were included in the qualitative synthesis. Higher physical activity levels were associated with lower odds of urinary incontinence, both cross-sectionally and longitudinally. Sedentary behavior was not clearly associated in the available analyses, and these are observational data. We cannot claim that increasing physical activity treats urinary incontinence, but the paper challenges a common fear-based message. Physical activity is not automatically harmful to the pelvic floor. In consultation, this supports activity adaptation rather than blanket restriction. Wang et al. In the Journal of Urology compared surface patch electromyography and needle electromyography for evaluating urinary sphincter function in children during urodynamic testing. Agreement was poor. In several cases, patch EMG suggested dyssynergia, while needle EMG showed synergy. Sensitivity and specificity of patch EMG for detecting dyssynergia were limited. Measurement tools are not interchangeable. In pediatric urology, when decisions depend on detrusor sphincter coordination, surface EMG may be insufficient. For PTS, it also reinforces a broader point. Surface EMG signals need careful interpretation. Zimmermann et al. In Urology summarized the German S2K guideline update on interstitial cystitis and bladder pain syndrome. The paper confirms that physiotherapy has a place in structured care for chronic bladder pain. The key point is not to reduce ICB-PS to either a hypersensitive bladder or a tight pelvic floor. Presentations vary, and treatment must be staged according to dominant symptoms. In male pelvic health, Velasquez et al. In Urologic Oncology analyzed real-world data comparing prostate gland ablation with radical prostatectomy, external beam radiation therapy, and surveillance for localized prostate cancer. Ablation was associated with lower early erectile dysfunction and urinary incontinence than radical prostatectomy, but higher urinary retention. 5-year failure-free survival was lower than with prostatectomy or radiation therapy. For pelvic health PTs, the functional aspect is important, but it must not overshadow oncological decision-making. Continence and sexual outcomes matter, but they cannot be separated from cancer control. Another paper in the prostate examined persistent incontinence after surgical treatment of benign prostatic hyperplasia. Incontinence decreased over time, but a proportion of patients still had persistent symptoms at 18 months. For follow-up, the message is simple. Leakage after benign prostate surgery should not be dismissed. Some recovery occurs spontaneously, but persistent symptoms require assessment. Anorectal disorders, constipation, fistula, and biofeedback. Chi and Lee published a meta-analysis in Academic Radiology comparing 3-dimensional endoanal ultrasound and MRI for anal fistula classification. 32 studies and more than 4,000 cases were included. 3-dimensional endoanal ultrasound performed well for intersphincteric and transsphincteric fistulas, but less well for suprasphincteric and extrasphincteric forms. Contrast-enhanced MRI had the best overall performance in complex cases, and this is not directly a rehabilitation paper, but it helps us understand care pathways. Before fistula surgery, mapping is essential to reduce sphincter risk. After surgery, if pain, discharge, recurrence, or continence symptoms appear, knowing what imaging was done helps communication with the surgeon. Omak et al. Was in colorectal disease evaluated home-based anal biofeedback in 24 patients with dyssynergic defecation. This was a prospective pilot study without a control group. Obstructed defecation scores and constipation-related quality of life improved after 12 weeks, and 75% of patients reached clinical improvement according to the ODS score. Evidence quality is low, but the topic is practical. Home biofeedback could reduce access barriers, cost, travel, embarrassment, and appointment availability. But before presenting it as a first-line option, we need better data on patient selection, initial training, adherence, safety, and instruction quality. Danmote et al. In Annals of African Medicine assessed high-resolution anorectal manometry for detecting dyssynergic defecation in chronic constipation patients who had not responded to conventional measures. 102 patients were included. Manometry identified dyssynergia in about 3/4 of participants with high sensitivity and specificity compared with balloon expulsion testing. So this is highly relevant clinically. In chronic constipation, especially after failure of laxatives and lifestyle advice, defecatory disorder must be considered. Constipation is not always slow transit. A functional assessment can change the treatment entirely. Defecation mechanics, abdominopelvic coordination, anal relaxation, posture, breathing, and biofeedback. Bigliardi et al. In the Journal of Pediatric Gastroenterology and Nutrition studied transcutaneous sacral neurostimulation in children with fecal incontinence, including refractory functional constipation, myelomeningocele, and anorectal malformations. 42 patients received 12 weekly 30-minute sessions with electrodes placed over S2 to S4. Complete continence was reported in 57%, partial continence in 26%, and no improvement in 17%. This is a quasi-experimental prospective cohort, not a controlled trial. Still, it is an interesting pediatric signal. The point is not that neurostimulation works for everyone. The point is that a non-invasive modality may complement treatment for refractory fecal incontinence, provided that anorectal assessment is robust. Rajendrajith et al. Follows in expert review of gastroenterology and hepatology, reviewed non-retentive fecal incontinence in children. The paper highlights social and emotional burden, but also the limited current understanding of pathophysiology. This review is useful because not all pediatric fecal incontinence is hidden constipation. If assessment is superficial, clinicians may keep repeating ineffective advice: sexual health, dyspareunia, menopause, and postpartum. Strandberg et al. In Maturitas compared vaginal DHEA and vaginal estradiol for dyspareunia related to vulvovaginal atrophy in postmenopausal women. 172 women were randomized. Both groups improved. DHEA seemed to have an advantage for dyspareunia, especially in severe cases, while estradiol improved some clinical and objective signs of atrophy more strongly. For PTS, the message is straightforward. Postmenopausal dyspareunia is not solved by one single explanation or one single manual approach. Tissue status, pain, fear, muscle activity, lubrication, sensitivity, and hormonal factors must be separated clinically. Salmeri et al. In Acta Obstetricia et Gynecologica Scandinavica reviewed the impact of combined oral contraceptives and progestin-only pills on psychological and sexual well-being in women with endometriosis. The authors did not find a consistent signal of worse psychological or sexual outcomes, especially when pain was controlled. The paper does not close the the debate. It suggests that the relationship between hormonal treatment and sexual function also depends on pain relief. Wahid et al. In Acta Obstetricia et Gynecologica Scandinavica published a systematic review on topical vaginal estrogens in postpartum women. Only 3 studies were included, with 85 women in total. Some signals suggest improvement in tissue or atrophy-related findings with acceptable tolerance and no serious adverse signal, but there is no solid evidence for urinary, bowel, or sexual function benefits. Ross, Shoberi, and Espunya-Pons in the International Urogynecology Journal published a narrative review on ultrasound in the follow-up of obstetric anal sphincter injuries. OASI is a major risk factor for postpartum anal incontinence. After sphincter injury, assessment should not stop at the scar looks fine. Symptoms, repair quality, residual defects, and future pregnancy planning may all matter. Gondim et al. Has in the International Journal of Gynecology and Obstetrics tested a single photobiomodulation session for immediate postpartum perineal pain. This was a randomized double-blind trial in 60 women. Pain improved in both groups, but photobiomodulation was not superior to sham treatment with the parameters used. A single application under these conditions did not show a specific benefit. Prolapse, pessary, surgery, and follow-up tools. Boom et al. In BJOG published a meta-analysis on graft-related complications and recurrence after minimally invasive sacrocolpopexy using biological grafts. 5 studies and 353 patients were included. Recurrence rates were highly variable, with a pooled estimate around 25.6%. Graft exposure was low, around 0.8%. Results varied by material. The message is important. Replacing synthetic material with biological grafts does not automatically solve the equation. Exposure concerns may be lower, but durability may be weaker. Lo et al. In the Taiwanese Journal of Obstetrics and Gynecology reviewed Taiwan's experience with transvaginal mesh for pelvic organ prolapse from 2004 to 2025. This should not be read as a simple defense of mesh. Regulatory context and indications differ between countries. The useful message is that technique cannot be judged without considering mesh type, surgeon experience, patient selection, follow-up, and functional outcomes. Wu et al. In BMC Women's Health compared single-port laparoscopic lateral suspension combined with total versus subtotal hysterectomy for pelvic organ prolapse. In this prospective cohort, cervical preservation was associated with better apical support and better sexual function scores at 12 and 24 months with shorter operative time. But the study was not randomized. Bun et al. In the Journal of Obstetrics and Gynecology Research looked at self-management of the ring pessary and its impact on fitting success and treatment continuation. Continuing pessary use is not only anatomical, it depends on the patient's ability to manage the device, symptoms, adverse effects, and initial fitting quality. Technology, AI, and health data. Lee et al. In Diseases of the Colon and Rectum evaluated large language models in the context of an expert consensus group on ventral rectopexy. ChatGPT 4.0, Gemini 1.5 Pro, and OpenEvidence were compared. OpenEvidence achieved the best content appropriateness and did not fabricate citations in this study, while ChatGPT fabricated many. The message is clear. LLMs may help synthesize literature, but fabricated references are a real issue. For scientific use, the tool must be supervised, traceable, and ideally connected to verifiable databases. A polished synthesis without source verification is not enough. Martini et al. In JMIR-AI assessed geriatricians' perceptions of accuracy, relevance, and safety of LLM-generated patient information across geriatric conditions, including urinary incontinence. In pelvic health, this is already happening. Patients come with AI-generated answers about leakage, pelvic pain, Kegels, or treatment options. The problem is personalization, safety, and red flag recognition. Another paper in abdominal radiology proposed an MRI radiomix nomogram to improve diagnosis of rectocele using MR defecography data. The model achieved good internal performance, but the study was single-center, retrospective, and lacked strong external validation. This is promising technology, not ready clinical practice. Finally, Monteleone et al. In Microbiome explored the use of mRNA-seq to better understand microbiome structure and host cell interactions in the vulvar ecosystem. This is not directly practice-changing, but it suggests that future understanding of vulvar pain, irritation, infection, and symptoms may become more precise than current clinical categories. Briefs. First brief, Young et al. In Journal of Women's Health analyzed the association between sugar-sweetened beverage intake and storage urinary symptoms in women using NHANES data. After adjustment, the quantity of sugar-sweetened beverages was not associated with storage symptoms such as nocturia or urge incontinence. More consistent associated factors included age, obesity, and depression. Second brief, Oishi et al. In BJOG looked at supervised individualized exercise during pregnancy and postpartum for lumbopelvic pain. The topic is clinically relevant, but methods and outcomes need to be reviewed carefully before changing practice. Third brief, Tremblay et al. Dafetiquoise, in Journal of Bone Care and Research, described pelvic and perineal rehabilitation after genital skin graft complications in 2 male patients following necrotizing fasciitis or Fournier's gangrene. Evidence level is very low, but the topic is rare and concrete. Conclusion: this week's corpus is broad but uneven. The strongest papers mainly concern endometriosis, vestibulodynia, urinary symptoms in Parkinson's disease, female urinary incontinence, postpartum care, and selected surgical topics. The practical thread is this: do not confuse anatomy with symptoms. Do not confuse improved muscle function with improved patient function. Do not confuse attractive technology with clinical proof, and do not interpret pelvic symptoms in isolation when the data suggest more complex mechanisms. For clinical practice, 3 points are directly useful: measure better, track concrete functional outcomes, and remain critical about emerging tools, whether stimulation, imaging, radiomics, or artificial intelligence. Always check the methodological details before changing practice. The full references are available in the description.